Great. Thanks again for having me. Just a little bit of history on me. I've worked on an ACT team. So with regards to assertive engagement and out there in outreach, I've been out there in the community doing that work. So I know what it's like and I know it can be challenging. So just want to throw that out there. Okay. So I created this in collaboration with a couple of the individuals I've worked with in the past. So just want to say thank you for their contributions, Katie McDonald and David Lind. Just figured to mention their names. Okay. So before we talk about the assertive engagement and outreach protocol, which we're going to get to, I want to first talk about what does the word engagement really mean and why is the word assertive in the title of ACT? So what do you all think? Why does ACT include the word assertive? I want you to put it in the chat. Why do you think the word ACT includes the word assertive? Why does ACT include the word assertive? Because we can go out looking for them. Absolutely. That's half the job, right? Being out in the community, trying to find our people, trying to help them. Absolutely. What else is the word assertive in there? Is engagement inherently low? So we're going to get to that. The short answer is probably. Yes. So with the individuals who have SPMI, serious and persistent mental illness, typically they have some symptoms that make their engagement more difficult than somebody that is, let's say, higher functioning, if we use those words. Assertive with ourselves. Let's see. We don't give up. Our population doesn't do well in traditional settings. Yes. Assertive with ourselves. We are a fixed point of responsibility. Yes, we're going to get to that. Assertive, most clients wouldn't engage. I think that's probably true. Overcome barriers, built up apprehension, resulting from years of feeling marginalized. Yes. Resistance, absolutely. Distinction to treatment, usually delivered in clinics where the clinician is relatively passive. So, yeah, so this is going to be different type of treatment, much different than traditional treatment, as y'all said. And engagement is really critical because we do have to get out there and be assertive. So what do I mean by that? Well, when you think about engagement, people with co-occurring serious and persistent mental illness and substance use disorders drop out of services. So 27% in a trial done, pretty extensive trial done, says 27% of people drop out of services. So it's really important for us to know what we're doing around keeping people retained. Clients in mental health care drop out of services at almost twice the rate compared to other medical specialties. Why do you think that is? Feel free to throw it in the chat as I keep talking. But why do you think people in mental health services tend to disengage quicker than in other sort of medical treatments? 70% that drop out do so after the first or second visit. So why am I mentioning that? I'm mentioning that because what we now know is that engagement is critical, especially when we first get to know a person, because we'll lose them. They'll drop out quickly. So yeah, I think one person said that, people drop out of services at twice the rate because they don't feel heard, they don't feel judged. I think what you're alluding to, Deborah, maybe is some of that stigma. And a lot of people see mental health treatment as stigma. We're not used to it. Mental health treatment hasn't been around as long as medical treatment. And so stigma is really common. People are marginalized, stigmatism. Yes, great. So what is engagement? Let's talk for a second. There was different definitions of engagement depending on who you kind of looked at, but engagement is supposed to be a strengths-based approach. Let's sort of dissect this. Helping people heal with a connection and support their recovery and wellness in the context of family, culture, and community. Okay, what the heck does that mean? Well, we're going to get into that. So when we think engagement, sometimes we'll use the word compliance, but that's not engagement. Compliance is asking a person to do what we say, whereas engagement is on the other end of the spectrum. It involves the person's participation. It involves the person's own expertise about themselves, the person that is in the services. It doesn't involve our expertise necessarily. It's a combination and it's a partnership. So engagement is about respectful, partnered care, compassionate care, and centered on the person's life goals rather than what we think they should do. Oftentimes as providers, there's a lot of things we think people should do. And that's all with well intentions. A lot of the things that we think people should do are for really good reasons because we've seen them fail. We've seen them in misery. We've seen them in despair, and it's really sad, and we want to help them. But sometimes what a really important part of engagement is understanding what the person wants. Because if we don't have that, it's going to be really hard to keep them in our to keep their attention, really. So I always say, like, what's in it for them? Not for us, but what's in it for them. So if we don't know their what's in it for me, we're going to be, we're not going to get very far with the person. So why do people disengage? Why do people refuse treatment? Go ahead and put some ideas in the chat. Why do people disengage and refuse treatment? What are some reasons? Let's see what you all think. You have a lot of experience in this room. There's a ton of you that have been doing this for a long time. So why do you think people disengage and refuse treatment? Low awareness of symptoms, yeah. Symptom that we might refer to as anosognosia. If you haven't heard of it, absolutely look it up. Rejection, isolation, away from partnership, lack of trust. Yeah, meds not working, stigma, poor attitude from providers, burnout from previous services. Yeah, people have had really poor experiences, lack of natural support. People feel like it's a waste of time. It's not effective. It's not working for them. People don't feel like they have choice. Yeah, these are all really great. Discordance between patient and the goals. Yeah, what we were talking about before, making sure that what we're doing aligns with what they want rather than just aligning with what we think. Just not wanting to concern terms with mental health diagnoses. Yeah, all that stigma. Feeling like a burden. Absolutely. These are all really great. Okay. So you mentioned most of these here: stigma, previous negative experiences, stage-wise treatment. So are we working with the person? Do we know their stage of change with regards to whatever goals we're looking at, whether it's substance use, where they are in treatment, working, whatever it is that we're working with them on? Do we know where they're at, and are we matching where they're at stage-wise treatment? If you haven't gone to a training on stage-wise treatment, go there. It's really, really beneficial and really, really imperative when you're working with individuals. So logistics, maybe we're not meeting with them at the right time or the right place or the right location. Maybe we're saying, we've got to come to your home, and the person's saying, I don't want to start off by meeting you in my home. I want to meet you outside my home. Okay, let's do that. Or, I work for a couple hours in the morning and you're trying to schedule morning time appointments. Okay, let's shift that. We're going to get to this, but not tending to their immediate needs. So if this individual doesn't have food, doesn't have a place to live, right, doesn't have any of that, it's going to be really hard for us to work on anything else if their needs aren't being met. So that's that Maslow's hierarchy of needs. Are we aware of that? Do we know what needs need to be met? Sometimes it's just cognitive challenges and forgetting. Are we helping them get reminders? Are we having natural supports help them remember? Sometimes it's anosognosia. Raise your hand if you've heard that term before. I'm just curious. So it sounds like a lot of people have heard that term. So, and we can too share a video in the chat about anosognosia later. Michelle, I don't know if you can pull that video up and put it in the chat for us, but really great video on anosognosia. If you haven't heard about it, watch it. It's a great sort of introduction about what it's like to have an illness like schizophrenia and not realize that you have an illness. That's a symptom. It's not denial. It's not refusal. It's a symptom. Sometimes disengagement and refusal has to do with symptoms. They don't feel well. They're depressed. They're anxious. They're using substances, whatever it is. Maybe we're not culturally sensitive to their needs and we're doing things that aren't working for them. Maybe we're deficit-based and strength-based. And just to kind of talk about that for a minute, a lot of the tools that we use sometimes make us look toward deficit-based. So when we're doing billing or when in your electronic medical record, it's asking for what? Symptoms and diagnoses. I challenge you to think outside of that. And while that's important, to really primarily be thinking about what is the strengths-based and what does the person want. So what are some other barriers to engagement? We're not using creative and innovative approaches. In other words, we're not individualizing our approach. We're sort of just doing the same thing with each person, which doesn't tend to work. Again, we're deficits based rather than strengths based. We're not working with diverse cultures. We are being rigid. We're saying we need to meet with you at this time, or the rule is this, when really maybe we could be a little bit more flexible. We're not respecting the person and their family and their natural supports. And we're not conveying hope. Maybe we're burnt out. That's a whole nother training, to think about where's our team at? Are they burnt out? Do they need help? Do they need time off? Those kinds of things. So this is a really great quote, and I'll just read it out loud to you. One participant described how, in her first experience with involuntary hospitalization, her personal items were taken away. They took away her clothes, school books, and notes. She was essentially stripped of everything and anything familiar, of anything that would keep her calm. The hospital focused on rigid rules and procedures rather than on her needs and what she was experiencing as a terrified young woman. There was no attempt to engage her in care. So let's say this person gets referred to your ACT team after this hospitalization. Feel free to use the chat. How might this person feel about mental health care after this experience? Right? This is going to create quite the challenge for you all to say, okay, this person had a really bad experience. We've, enjoy a good challenge, because it's going to be one, because this person has had really negative experiences. So let's see what Jill said. Fearful, limited, no trust, terrified. Mental health care doesn't work. Absolutely. So a lot of individuals have had these types of experiences, and we need to be sensitive to that. So in some respects, ACT is actually worse than being in the hospital. Because in the hospital, there's solidarity, there's people helping each other, lived experience, and the only issue you have is getting out. But when you're out, you have to deal with ACT, which leads to a host of other problems. And I'm just going to read the second half of this. ACT members tend to be intrusive and authoritarian. It's chilling to know that anything I do or say will be judged and duly noted in my chart. There was little incentive to tell the truth, as the very real possibility of a mental health apprehension is always present. What does that mean? It means that the person feels like they're always being judged, feels like they're always going to get in trouble for not complying with treatment, for not doing what we think they should do. It's a really crappy place to be at. It's a really scary place to be at. And we need to be aware that when somebody is on an ACT team, it can feel pretty paternalistic, and it can feel like their autonomy is being taken away. And it's not just a feeling, it's true. We'll get into this, but ACT teams have sort of been criticized for that. And so we just need to be really, cognizant of that. So why do we persist? So when people say, I don't want to work with you, they're disappearing, they're not showing up. Why do we persist with continuing to try to work with people? Well, first and foremost, because research says ACT works. So we continue to persist because what we know is we're going to help people have less hospitalizations, a better quality of life, more independent living, decreased substance use, higher rates of competitive employment, more satisfaction with services, and retention in treatment. Why else do we persist? Because if people don't engage, they're at higher risk, and we need to know that. So if we're feeling frustrated and we stop engaging with someone, they're at further risk for deterioration, relapse, and hospital readmission. And lastly, because people recover. From the famous Pat Deegan, our job isn't to judge who will and won't recover. Our job is to establish strong relationships to maximize the chance of recovery. We need to have the dignity of risk and the right to fail. So what that means is, if somebody wants to try something, we have no right to say, no, you shouldn't do that, right? Our job is to best support them to try and figure it out. And if they fail, learning experience, let's help them work through that. So we can't, help people do things that we think they should be doing, like get an apartment, move on, get a girlfriend, get a cat, do a hobby, address legal charges if they drop out of services. And I've heard other people say, or if at worst, they go into a hospital or they die. So this engagement piece is really important, because we need these individuals around if we're really going to help them. So one of the things about engagement before we get into the protocol is just all of these factors that I was just talking about is all around engagement culture. So the way that I was communicating with you all about engagement is, I would ask you to ask yourself, is that the culture on your team? And if it's not, I would challenge your team to sit together and talk about what does engagement mean to you all, and maybe come up with a sort of your own action plan on how to sort of come together better. Engagement and outreach culture might look like, that you're often portraying hope rather than burnout. You're including others in the person's care. You're talking, respectfully, person first language, sharing strengths rather than just deficits. You're talking about each person on an individual, unique basis rather than sort of every update sounds the same. You're meeting people where they're at. You're considering their community, their diversity, their culture. You're including people with lived experience. I want to exclamation point that. It's really important. Shared decision making, educating staff about informal supports and peer importance, and collaboration among all outside systems, whether that's, parole, hospitals, primary care physicians, whoever it might be. So I was talking about this a little while ago, but there's a balance here. So in some sense, on the bottom here, we need to promote autonomy. We need to let people try, even if we're nervous they might fail. On the top, pushing down on the other side, is that paternal side of ACT. So we need to balance being able to let people be independent, but also we need to make sure that we're not letting someone get hurt or harmed, and we're reducing safety risk. So when do we really know when to push hard and do things that seem paternalistic, and when to step back and let people be, independent? So it's a really hard balance as an ACT team, and it takes a lot of practice. But one thing with engagement and outreach is that, it takes time. So it's a marathon, it's not a sprint. I like that analogy, meaning sometimes it takes months and years to engage people, especially individuals that you've just met. Don't expect that they're going to want to work with you. You need to get to know them. You need to remember, to ask them, what do they want in these services? How will you remember what you have and haven't done if engagement takes time? And how will you know what has worked and has not worked over time? Are you just going to memorize that? Probably going to be really hard when you have multiple individuals, to worry about on an ACT team. So that's where the assertive engagement and outreach protocol can help, because there's no way that we're going to remember what we have and haven't done over the past several months or years with an individual without having it documented somewhere. And there's no way we're going to memorize and have it at the top of our list of 100 different engagement and outreach strategies. So let's talk a little bit more about that. Having a written tool means that you can refer back to what's worked and what hasn't in the past. Having a written tool can be used as a checklist so that you can go down the list and go, what have we tried? What did we forget to try? What has worked in the past and what has not? When you're using these lists, they're going to come up because you're talking about every client during every daily team meeting, not new information to you all, right? And so part of those daily team meetings, when you're talking about every client, is you're talking about engagement. So when you have someone that comes up that says, this person's really struggling with engagement, that's when you pull out this protocol that you're going to see in a minute here. Just as a reminder, nobody should be removed to services due to disengagement. I always like to put that in there just as a friendly reminder. Okay. So before I show you the engagement and outreach protocol, I want to play a little game that is really sort of just going to illustrate how many engagement and outreach strategies, there are really. So when you think about engaging someone and or literally going out and finding someone, what are some of the strategies that you all use? So typically what I do is I put people in two groups into breakout rooms, but I'm not sure if you guys usually do that in Echo. And in the interest of time, maybe the way we'll do it is if you all could just put in the chat, what are some different engagement and outreach strategies? So typically I'd put you into two breakout rooms. I'd have you guys come up with lists, see which group can come up with the bigger list, and then throw fake candy at you. But in the interest of time, why don't you put in the chat, what are some different engagement and outreach strategies that y'all use? Creative here. So like not calling, not texting, not, going to their house. What else do you use? Going for a walk. Yeah, try not to repeat what somebody else said. Let's see. Taking them to an arcade. I love that. Food, coffee, going to different locations or places they might go during the day. Yeah, they're known spots. Taking a person where they want to go, the beach, the park, the zoo. Uh, Drives to enjoy the weather, fun activities, card games, grocery shopping, contacting informal supports. Good. Trip to the beach. You guys do the beach a lot. I love this. Food bank, watching football, seeking them out places they frequent, doing art together, something they don't get to do otherwise. Yeah, offering them a new opportunity. Great. Going to the bookstore, library, intellectual engaging activities, golfing, places where they enjoy, dog park, library, showing them new shops or businesses that align with their interest, playing pool, games, video games, taking out and watching the planes take off. That's great. Watching wrestling, cooking. Yeah. So how many strategies did we just say in this chat? I didn't count, but several. And that's just dipping our toes in. And so there's going to be a lot. Let's see, someone else just put connect them to locations with additional services like hot meal locations for engagements to help them learn where to get assistance outside of ACT. Yeah, so connecting them to resources, getting their basic needs met. So just dipping our toes in and spending 2 minutes on engagement and outreach strategies, we've come up with, I mean, y'all put at least 50 things in that chat. So again, this just goes to show that having a written protocol with different ideas on it is really important because our brains can't remember unless you're, I mean, if you can, yay to you, but most of us, our brains can't remember, 50 to 100 strategies. So strategies are sort of broken down into different categories. So there's individualized care components. And what that really means is unique, personalized planning. Do we know what they want to work on? Do we know their goals? Tending to practical needs. So this is the Maslow's hierarchy of needs. Do we need to help them get their basic needs met or feel safe? Logistical approaches. Are we meeting them somewhere that is convenient and safe? Team-based strategies. Are we using the people on our team that have the good rapport? Are we doing dual meetings where 2 people go to introduce someone? Warm handoffs, peer support, whoever it might be. Are we using outside resources such as natural supports, whether that be family, friends, the pastor, parole officer, whoever it is? Are we using people out on the outside? Are we considering evidence-based strategies such as motivational interviewing, enhanced illness management and recovery, CBT, all of those fun evidence-based practices that we know work and we know engage people? And last, and I was going to say certainly not least, but kind of least, is those legal mechanisms. And those are as a last resort. Does that person need to be, for example, involuntarily hospitalized? Does that person need their parole officer called and say, hey, where are they? All right. And again, those are a last resort, but being able to know that different engagement outreach strategies are broken into sort of different categories. And that order here is, is intentional. So those top 2 things are really important. So I just want to go over just for a minute, intrinsic and extrinsic motivation before we see this list on the protocol. So intrinsic motivation builds on what the person wants internally, based on their values, based on their goals. It's a collaborative motivational approach, and it's us really learning about what they want. It's based on self-determination, independence, autonomy, and this should be the primary method. So, okay, what if that doesn't work and the person is unsafe? We're worried about them. We're really fearing for how, for their life or their well-being. Okay, if we don't know this first, that's important. Okay, we really need to know their intrinsic motivation to working with us. But if we don't, the next thing we need to do is build on extrinsic motivation. And what does that mean? It means sometimes we need to invoke power, and that's not good to do unless we really, really, really need to. And we only should do this if the person is at risk of harm to themselves or others. These are that paternalistic approaches that sometimes people overuse, and we just need to be really, really wary of that. And we're only using these extrinsic motivations when collaborative approaches have failed. Outside of that, we shouldn't be using extrinsic motivation. So I'm going to go back to my previous slide. So just to kind of summarize the extrinsic versus extrinsic motivation, from Maggie, a person in services, she says, don't generalize about people based on their symptoms and mental health issues. Figure out what their goals are and what they want to do in life. Then cheer them on and listen that it's possible. Listen to their whole story and cheer them on. Then if obviously, if that doesn't work, we go to next strategies. So again, extrinsic motivation, we've been criticized for using that for good reason. And this is something that, we need to track and make sure we're not doing with a bunch of clients. If you look at your caseload list, which I recommend you do, try to sort of categorize, are we using intrinsic motivation to engage these individuals or extrinsic motivation? And if you see that you have a lot of people in this category where you're utilizing sort of that paternalistic approach where you have sort of more power and control, do a check, see if you can shift to the intrinsic side, because the extrinsic motivation tends to push people away. Okay. So creative engagement techniques might not show up on this protocol. Y'all listed a bunch of them in the chat. Things like, taking out to coffee, showing up on time, listen more, talk less, show humility, fight legal charges, drop off a Gatorade with a note, take them to the store, help them with advanced directives, all those things. So I just want to note that, unique strategies might not be listed on this protocol. All right, so let's take a look at how to use this protocol and see what it looks like. So there's two sections on it. One is, the top section is if the person can be located but is not engaging, aka we sort of know that they're around, we've seen them semi-recently, they haven't completely disappeared, and we need to really work on just engaging them back in services. Then the next section is we can't find them. We don't know where they are. We haven't seen them in a while. We're really worried. What do? We can't find them. Okay. So this engagement and outreach protocol is to be used with each individual person. So it's a document. Some people print it out and use it. Some teams add it to their electronic medical record, however you all want to do it. But let's say you print it out. So you'd have this printout and you'd say, okay, Johnny's not engaging. So let's talk about when's the last time we've seen Johnny. And what are some possible reasons for disengagement, that we might consider? You kind of list those. Okay, good. Now we know. So what are we going to do? We're going to have all these methods that we're going to look at, and we're going to sort of go down the list to see what have we tried and what have we not tried that we should try. Okay. And then you'll see there's these different columns that within that, what have we tried and what do we need to try? It's the method. You want to put the date, who did it, and what was the outcome. Why do you suppose tracking it is important? So we could just have a checklist, and I've seen teams do this. There's just a checklist of different methods, but why do you suppose tracking it in this way might be important? Why do you suppose tracking it could be important? Yeah, a pattern of recognition. So what has worked in the past? What has not worked in the past? So let me give you an example. Let's say Josie, we can't find Josie. And, maybe she disengaged about a year ago. And we say, geez, this happened about a year ago. Can't remember what happened, but, so then you pull out this assertive engagement and outreach protocol that you filled in a year ago. And you look at it and you go, oh, she went to her Aunt Rosie's. We forgot about her. So she's probably at Aunt Rosie's again. Let's call Aunt Rosie. Guess what? It's more efficient. You skip everything that you don't need and all the fluff, and hopefully she's at Aunt Rosie's again. So, and then also, it didn't happen if you didn't document it. So that's the other reason. Okay. So let's take a closer look. Now you know how to use the document. Okay. So here's some things on the document. So first and foremost, do we understand their viewpoint, what they want to work on, and the goals that they want to address? Secondly, do we need to tend to practical needs? Think Maslow's hierarchy of needs here. We often forget about that. We're working, we don't understand why they're not meeting with us, but they don't have food in their fridge and they haven't told you that. So being able to check in and say, how are you doing? How is your housing? What have you had to eat today? Let me take you to McDonald's, whatever it is. And then, you all said this, but have you visited their home in known spots? Have we asked them about where and what time we've been meeting and the logistics? Has that been working for them? Now, the obvious thing in all of this is obviously if we can find them, you're going to ask them what's getting in the way, right? We'll assume that you didn't get a clear answer. You're not sure. Okay. So is it a comfortable place that they're meeting? Do they have transportation? Do they need transportation or a ride somewhere? Do they like technology? So do they need a text reminder or would they rather a call reminder, for example? Are we doing things at the right time of day? Now, you might take this protocol, and I wouldn't take it out and use it with a person. I wouldn't say, hey, do you like this? I wouldn't do it that way, but it's certainly a tool that you could sort of go down the list while you're working with someone and say, you know, are you okay with the times we're meeting? Do you like where we're meeting? And sort of interview them around, what is getting in the way if they can't clarify for you. So if the person has a substance use disorder, that's sometimes often where we kind of get a standstill as well. And that might be because we're not using stage-wise approaches. So maybe somebody's in pre-contemplation, but we're trying to do things that are related to the action stage of change, right? And we're not doing, for example, harm reduction. Maybe they need a ride to their co-occurring disorder group or they're never going to get there. Maybe they want to do self-help groups. How are they going to get there? And just being sensitive to the SOC is the stage of change. Does the person know how to get in touch with you all? I've seen this happen a bunch of times. Why didn't you show up to your appointment? I didn't know how to get in touch with you, but I had X, Y, and Z, and I didn't get in touch with you. Do you all have, for example, magnets or pamphlets? Is your information for people that have cell phones, is your information programmed into their cell phone, for example? Have 3 or more ACT members attempted to engage the person? Somebody might have a better rapport than another person, and rapport may have shifted. So you might think it's Whitney, for example, but now they like Michelle better, right? So being able to, shift off and exchange and seeing who can do what. Have we gone to visits together? So maybe it's Whitney that they love. Hey, Whitney, can I tag onto your appointment with you to go visit so-and-so? So being able to do that. Have you just engaged in an activity with them that they enjoy? I've heard people say, well, I don't want to go play basketball with them. Like, that doesn't seem right. It does seem right because the person isn't going to get services if you don't keep them engaged. So it is okay to go and play basketball with somebody. Now, going and playing basketball with somebody over and over again and doing absolutely nothing else in the appointments, that might be a flag. But if you can use that basketball, you probably are going to be doing therapeutic services while you're playing basketball. Hey, how's it going? Are you getting outside? You can do therapeutic services and do fun things at the same time. And again, if you don't do that, person might not meet with you and then you're not doing services at all. Does the person know what everyone's role is? So has the person, have you reviewed who does what? Maybe they don't know the employment specialist helps with schooling or work and they want to do that. And we just didn't know they wanted to do that. Maybe they didn't know that there was a peer support specialist and someone on the team that had shared lived experience that they'd rather talk to and be more comfortable with. Are there cultural differences? I think we're going to talk about that in the case study, right? That comes up all the time. Again, I'll bring it up again. Are we using stage-wise treatment? So are we matching with their stage of change on how we're working with them, depending on what behaviors are, what their goals are? Have we consulted with people's informal and formal supports? So their emergency contact, their rep payee, their guardian, their landlord, their previous provider, probation, parole, medical providers, family, friends, roommates, people at the library. It'd be a whole nother training to sit here and talk about how do you figure out who people's informal supports. I could get on my soapbox, but I'll just really quickly say that try not to assume when somebody says, I have no supports, that they necessarily don't have supports, because oftentimes they don't feel like they have supports and they might not have really strong supports. But oftentimes people do have people in their lives that they don't realize are supports. For example, if you ask somebody, tell me about your week or tell me about a day, and then you find out that, every Friday they go to the library and hang out with the librarian for 3 hours. Guess what? That librarian is a natural support. Or you find out they go play guitar with their neighbor every couple weeks. Guess what? That neighbor, probably a natural support. Or that they call their Aunt Sally once a month and FaceTime for 3 hours. Guess what? Aunt Sally, natural support. So being able to know who those people are on this list and being able to elicit more of them, and also being able to help them identify new supports. Maybe they met someone at a peer support group and there's someone in there they connected with, helping support them in growing those relationships. So enlisting the previous provider to get their help. Does the person need a crisis intervention? So, being able to do crisis planning with them. Have we been canceling appointments? And if we have, do we need to apologize and address that? Are we saying if they don't meet with us soon, we're going to terminate services, right? That's not going to engage people. And have we utilized evidence-based practices such as MI, motivational interviewing, peer support, the dual disorder approach, group services, making sure that we're offering all these different evidence-based practices that we know has shown to engage individuals. And then I put this at the end purposely, and these are those extrinsic motivation stuff. Do we need to go to the legal route and consider involuntary hospitalization? I know you all have different terminology here. I'm from New Hampshire. So revocation of CD is a revocation of conditional discharge in New Hampshire, meaning they have a commitment to do services, and then you can revoke that and send them to the hospital. So I know your terminology is probably different. Using their guardian or their payee or their probation or their parole. And then, of course, we have an other section. Okay. So those are just some ideas. Now, what if we can't even find the person? Some of this is sort of repeated, but we'll go over it real quick. So phone, texting, letter, email, being sure that we've done all of those. Creative messaging, I can't stress this enough. So are we texting people saying, hey, I missed you for your appointment today? Can you please call me back? That's not creative messaging. Creating messaging is, hey, I'm going to Dunkin' Donuts at 4:00. I'd love to come by and scoop you up to get you a coffee. Hey, your SSI check is waiting at the front desk. Come on over and pick it up. Hey, I have, Whitney with me who you love. We'd love to stop by, right? Things that not just, hey, where are you? What's going on, but creative messaging, right? You're selling it. You're a salesperson at this point, trying to pull them in, and that's okay. Because remember, if you can't pull them in, you're not providing services. Have we stopped by their home, their known spots? Have we had different people on the ACT team look for them, more than just you? Have we connected with, again, informal and formal supports to call people and say, hey, have you heard from them? Have we stopped by or called local places and community places like homeless shelters, food pantries, police, jails, hospitals, nursing homes, rehabilitation centers, right? Maybe they're inpatient. And then other steps, based on team discussion. So one last gentle reminder, because I know I'm up on my time here. But if we can't get these, just one last reminder, if we can't get these two top things right, it's going to be tough to utilize any of the other methods, right? So if we don't know what they want us to help them with, and we don't know their recovery vision, they're not going to want to work with us because there needs to be something in it for them. And if they're not safe and don't have their basic needs met, it's going to be really hard for them to work with us. So those two things are incredibly important. And I would just say, look at those two things before you consider anything else anytime someone starts to disengage. So what's the top secret to engagement? And I love this quote: people are generally better persuaded by the reasons which they have themselves discovered than by those which have come into the mind of others. Questions? Comments? And I'm going to put the engagement protocol in the chat.